I'd like to get started and welcome everyone to this session, A Decade in the Making, Optimizing the Holistic Approach to the Evaluation and Management of Chronic Kidney Disease, a KDIGO sponsored event. Importantly, some housekeeping things. Your microphones and cameras have been disabled for the duration of this webinar. The meeting is being recorded, so it's available afterwards for on-demand use. And if you could please submit questions to the speakers to answer in the future in the Q&A feature, then we'll be able to collate them and read them out towards the end of our panel discussion. We're going to answer as many as we can during the time that we have, and we will respond to the rest of them offline. If you have any technical assistance, you can also put your query into the Q&A or the question and answer category. So this second of 5 webinars from the KDIGO 2024 Guideline Update is called Leaving No Stone Unturned, Optimizing the Management for Patients with Chronic Kidney Disease. And I'm delighted to be able to share with you our very distinguished speaker panel, some of whom were actually involved in the guideline development. So Dr. Madero, Dr. Rossing, and Dr. Kazancıoğlu will be actually speaking to the different components. And I have the privilege of both sharing the guideline and sharing this meeting as well. So welcome, everybody. The learning objectives for today are to identify the members of the multidisciplinary team that are required to optimize the management of kidney disease, to recall the recommended drug therapies to manage and delay the progression of kidney disease, to recognize the potential risks associated with pharmacotherapy such as hyperkalemia and how we mitigate these risks, and to describe the importance of drug stewardship and medication management to reduce risks and mostly optimize outcomes in people with chronic kidney disease. And so the agenda is, as you see there, we're going to talk about lifestyle modifications, practical considerations, who and when, and a risk-benefit ratio with an emphasis on medication management, and then have some time at the end for a panel discussion, and then we'll close. So without further ado, it's really a pleasure and an honor to be able to introduce Dr. Magdalena Madero from the National Heart Institute of Mexico City, who is also a member of the working group. Over to you, Dr. Madero.
Thank you, Dr. Levin, for this very kind introduction. And for the next 10 minutes, I will be discussing the lifestyle modifications that we wrote about in the guideline. So, as we all know, the management strategy for CKD involves a multidisciplinary approach. So this is not only a matter of the nephrologist. A lot of people need to be involved in terms of taking care of a patient with chronic kidney disease, starting from a dietitian, primary care physician, cardiologist, endocrinologist, and other healthcare providers. So the first part of the guideline in terms of intervention talks about health and lifestyle modifications, such as physical activity. We are recommending moderate physical intensity exercise for a duration of over 150 minutes per week, smoking cessation, and the dietary advice, and I will be discussing this in a little bit of more detail in the next few minutes. We are advising an increased plant-based, a decrease of ultra-processed food. We are recommending maintaining a protein intake of 0.8 grams per kilo per day and reducing sodium intake less than 2 grams per day. I won't be delving a lot into pharmacotherapy, as Dr. Rossing would be discussing this, but it's important to understand that healthcare providers should educate patients, and nephrologists, we are supposed to be taking care of these patients when CKD enters later stages. However, primary care physicians are well placed for screening, detection, and management of early stage CKD, as well as any comorbidities such as hypertension. And then, on the other end, cardiologists and endocrinologists should manage risk factors for CKD, such as heart failure and type 2 diabetes. And other healthcare providers, such as pharmacists and nurses, are well placed to help patients manage their condition and promote drug stewardship. Will be great to have psychological care to support patients with their changing diet, lifestyle, and pharmacotherapy. I think this is very important in terms of adherence and social care support, and educate patients to better understand their condition of chronic kidney disease. Sorry. So we are recommending a holistic management, which involves, again, lifestyle modifications, pharmacotherapy, and regular risk assessment. And this is one of the figures from the guideline, where you can see at the top, we always put lifestyle on top, and then we go on to first-line drug therapies, and then target therapies for complications, which I won't be discussing at this point. So we should encourage, from the cardiovascular health and frailty, people with CKD to undertake physical activity, but this should be compatible with their cardiovascular health, tolerance, and level of frailty. Healthcare providers should provide advice on the intensity of physical activity and the types of exercises to those at higher risk of falls, for instance. The type of exercise is important. People with CKD should be advised to undertake moderate intensity physical activity, again, for at least 150 minutes per week. Avoid sedentary behavior. And other considerations that are important are we should consider age, their ethnic background, presence of other comorbidities, and access to resources. And smoking cessation, it's a big one. Referral to providers and smoking cessation should be offered when indicated and available. So, optimum weight, we have discussed this in depth. We should encourage people with obesity and CKD to lose weight. I understand this is easier said than done, but we should always take some part of our clinic time to discuss these issues. Type of diet, healthy diets, we again are advising higher consumption of plant-based foods compared to animal-based food, and lower consumption of ultra-processed foods. And protein intake, we're maintaining the same recommendation that we had from the 2012 guideline of 0.8 grams per kilo per day, and avoiding high protein intake over 1.3 grams per kilo per day. Sodium intake should be maintained less than 2 grams a day, or which equals less than 90 millimoles, or less than 5 grams of sodium. And, this is also in line with the blood pressure KDIGO guideline published in 2021. So, as you could see here, I wanted to discuss this briefly. Protein restriction in previous guidelines has been very diverse. You can see that, people have gone down from 0.6 to 0.8 over to 0.3 to 0.5 grams per kilo in those with GFR less than 20. In 2012, we set 0.8 grams per kilo. However, this is quite different from the KDIGO guidelines that were published in 2020, where they recommend 0.6 grams per kilo in anyone less than 60 mLs per minute, and this was graded as a 1A recommendation. In the last couple of slides, I just wanted to discuss a little bit of this evidence. This is low protein diet versus normal protein diet. This is for non-diabetic adults with chronic kidney disease. And what you can see here is that when you look at outcomes, the certainty of the evidence, let's look at this, death, right? The certainty of the evidence is only moderate, and, the relative effect, the confidence interval process, the unity. And for kidney failure, again, the certainty of the evidence is quite low, and this is also non-significant. Again, when you talk about end or change in GFR, when you compare low protein diets to normal protein diets, the certainty of the evidence is very low. So we are recommending plant-based diet, although this does not have the strength of the evidence that other pharmacotherapies has. This is mostly based on observational studies. However, we know that plant-based diet could decrease blood pressure, decrease obesity, help with weight loss, and improve glycemic control. It could help with CKD complications such as hyperphosphatemia. Less bioavailable phosphorus in plant-based foods decreases acidosis, which in turn can diminish the risk of hyperkalemia, decreases constipation, helps with fiber intake, and promotes fecal potassium excretion. Risk of CKD progression and outcomes, again, the evidence here is not as strong. There's, again, observational data that talks about the decreased risk of kidney progression, hyperfiltration, could help the gut microbiota, could decrease albuminuria and the risk of mortality. And well, it also has an environmental impact with gas emissions and water use. So with this, I will finish my section, and I will introduce our next speaker, which is Dr. Peter Brossing. He's an endocrinologist from the Department of Clinical Medicine at the University of Copenhagen, and he was the chair of the recent diabetes CKD guideline. Thanks, Dr. Brossing.
Well, thank you very much for the opportunity to be here today and talk on the practical considerations. And I think when you mentioned lifestyle, which is in a sort of foundation, and then when we talk about the treatment interventions, we could think about direct things like slowing kidney function decline and reducing proteinuria, but also indirect factors or treating risk factors like hyperglycemia in diabetes, hypertension, and dyslipidemia. And a new foundational therapy has been SGLT2 inhibitors based on these 3 trials, first in type 2 diabetes and kidney disease, then in mixed CKD with or without diabetes, in DAPA-CKD and IMPACT-Kidney, showing that in a broad range of people with CKD, SGLT2 inhibitors lowers the progression of kidney disease and kidney and cardiovascular mortality highly significantly. So this made it into these guidelines because this is really a major improvement. So in that sense, the pharmacological, you could say, foundational therapy has been blocking the renin-angiotensin system. That has for decades been our foundation in CKD treatment. And you could say here the problem is probably that although it has been the guidelines for a long time, we are not always using ACE inhibitors and ARBs according to what we should do. And we are often, when using it in too low doses. So the message in the guideline is use them and remember to up-titrate to the highest approved and tolerated dose. And don't be afraid if there's a small increase in creatinine or decrease in eGFR. That's probably just reflecting the hemodynamic effect of the medication. For SGLT2 inhibitors, they now are new in these CKD guidelines, coming from the diabetes guidelines, where we have recommended for anybody with diabetes and CKD with a kidney function above 20. If you don't have diabetes, it's also now in the guidelines, particularly if you have proteinuria above 200 or albuminuria above 200 milligrams per gram. And also if you have impaired kidney function without increased albuminuria, then there's at least a suggestion that you should use SGLT2 inhibitors. And once you've started with a GFR above 20, you can continue until dialysis, as was done in the clinical trials. You should remember to stop if you have intercurrent illnesses, critical illnesses, for instance, infections and fasting, as that could provide ketosis otherwise. So these are now foundational therapies in CKD management. Also important therapies in diabetes and chronic kidney disease are the non-steroidal mineralocorticoid receptor antagonists demonstrated to work in type 2 diabetes, also across a wide range of CKD with GFR above 25 and albuminuria from 30 milligrams per gram and above. GLP-1 receptor agonists have been recommended in the guidelines for their cardiovascular protection added to the glucose and obesity or weight reducing benefit of these agents. So maybe they will also have effect on kidney function, but we'll learn more about that later this year. Now, when we treat, it's important that hyperkalemia is often a problem, particularly for RAS blockade and for MRAs. The risk of hyperkalemia is an important concern because there's a lot of fear for hyperkalemia. And the risk for hyperkalemia increases with decreasing kidney function, as you will all be aware. You also know that increasing hyperkalemia is a risk factor for heart failure, kidney disease, and other adverse events. But also note in the graph to the right that decreasing kalemia or hypokalemia is also a risk factor and may actually be even more dangerous than hyperkalemia. So be aware of hyperkalemia, and we should follow potassium levels, but we should not be concerned about increases to a modest extent in potassium. And as I mentioned before, it's important to use the highest dose of RAS blockade. There are several studies that have demonstrated there's a dose-dependent benefit of these agents. So if you only use a small dose, you'll only get a small benefit. And if we look into the risk of hyperkalemia, then approximately up to 20% may have a risk of hyperkalemia with RAS blocking therapies. But if we look into why people stop treatment, it's often because of hyperkalemia if potassium is above 5.3, as you can see in the lower graph. So if you have an event of hyperkalemia, often RAS blockade is stopped. And that may be fine in an acute situation. The problem is we should remember to restart the RAS blocking therapy, and that's often forgotten, unfortunately. So it should not be a discontinuation, but it should be a treatment pause, or it should be a reason to consider what could be done to modify potassium levels. And the reason why I try to highlight that it's important to continue or restart the RAS inhibitors is that if you don't use these agents, you may reduce hyperkalemia, but you also increase the risk of mortality, both overall mortality and cardiovascular mortality. So that means that we need to ensure as far as possible that people are treated. So of course it's a balance, and in some situations we need to do something about hyperkalemia, but it's important to consider if we can do other things than stopping the RAS blocking intervention. So you can say when you start RAS blockade, look out for creatinine and potassium. Be aware that there could be changes in potassium or creatinine. And if there is a drop if there's no change in potassium or kidney function, well, then you up-titrate to the highest dose. If there is a risk or event of hyperkalemia, then consider if there are other drugs that you can modify, other potassium supplements, potassium-sparing diuretics, and you can add drugs like thiazide or loop diuretics that can reduce hyperkalemia. You can use potassium binders or bicarbonate, and you can also use the SGLT2 inhibitors, which will also reduce the risk of hyperkalemia. And finally, if there's an event of drop in kidney function when you start the RAS blocking therapy, consider hydration status. If there are other agents that are kidney toxic, like painkillers, and consider, of course, renal artery stenosis, although that's often rare. In rare cases, we may need to stop RAS blockade, but too often we stop. And all the epidemiology demonstrates that we are not good at maintaining this therapy. So please pay attention to this. What about the change in kidney function when you start an SGLT2 inhibitor, or for that matter, a RAS blocking intervention? With the SGLT2 inhibitors, many trials have demonstrated that some patients there will be a drop, in others an increase, and actually for the long-term outcome, it's not very predictive. It's not dangerous, and you should not be concerned of these initial changes. The higher the baseline, the larger the dip, or in other words, if you have a low kidney function, it's very rare to have a large change in kidney function. So don't be concerned that you'll push people into dialysis if you start an SGLT2 inhibitor, even if there may be this initial dip. And actually, some have found in some studies that this dip is associated with beneficial outcome, which probably reflects that this dip is a sign of reduced intraglomerular pressure, or in other words, a reflection of the benefit of the drug. And often you see after this initial dip, there is a stabilization and a slower progression of kidney function compared to those that were not given these medications. Now, you saw this before, and Magdalena highlighted lifestyle is important. But there's also other pharmacological interventions which are important to consider in addition to RAS blockade, SGLT2 inhibitors, and the non-steroidal MRAs and GLP-1 receptor agonist, because we need to deal with the risk factors as well, meaning hyperglycemia, hypertension, and dyslipidemia. And you can say, in addition to RAS blocking agents, calcium channel blockers are often a good choice in resistant hypertension with preserved kidney function. The classic MRAs are recommended for their blood pressure lowering effect, although we don't have long-term kidney protective outcome trials with these agents, but they have been demonstrated to reduce resistant hypertension. And then lipids are important. The majority of these patients will not die from kidney failure, but from an excess of cardiovascular risk. Therefore, we need to deal with all the cardiovascular risk factors. Of course, also stop smoking and consider antiplatelet agents, which has to be balanced to the increased risk there are in these patients for bleeding. But high-dose statins or PCSK9 inhibitors may be important in people with elevated cholesterol and CKD, given the high risk of the atherosclerotic events in this population. And of course, in addition to lifestyle up here, or as part of this, smoking cessation and the healthy diet are really important, as we also heard before. So this overview of the opportunities we have, both the lifestyle and the pharmacological interventions, really highlight that we have been given a lot of opportunities to prevent progression of CKD. And we can discuss if we need to add all of these agents in everybody with CKD, or if we can select a number of these or part of these. And at least in diabetes, it has been recommended to use reduction in proteinuria as a surrogate for the benefit or the success of your intervention. So you should aim for at least a 30% reduction in albuminuria. But maybe we need actually to combine with many of these agents if there's signs of progression, because they seem to work on different mechanisms in the physiology of or progression of kidney disease, and thereby combining, for instance, RAS blockade and SGLT2 inhibitors, MRAs, and GLP-1s may add benefit every time, reducing progression of kidney disease and also increasing the benefit on cardiovascular outcomes. When we are dealing with both lifestyle and this kind of pharmacological interventions, of course, shared decision-making is important. We need to do a good information of people with CKD. We need to revise medication on an ongoing basis, make sure we stop therapy that could be potentially kidney toxic, and implement the treatments that are needed to control the risk factors and to stop progression of the kidney disease. We, of course, should have people with kidney disease or patients in focus, and we should have a plan and follow the plan and update the plan according to how the disease is progressing. And then, of course, it can be important to reconsider not just to start medications, but also sometimes to stop medications when they are no longer needed, or if there are side effects, of course. So with this, I think I will hand over to Dr. Kazancıoğlu from from the Besmeyelim Vakıf University in Turkey, and she will talk about benefit-risk ratio and medication management in chronic kidney disease. So over to you.
Thank you, Dr. Rosing. I will just start from wherever you have left us. As you were discussing about, our people with chronic kidney disease have multimorbidities, having high blood pressure, cardiovascular diseases. Many of them have diabetes, and hyperkalemia, as you have mentioned, becomes a problem, and they are progressing sometimes towards the end-stage kidney disease. And also the anemia problems, metabolic acidosis, or mineral bone disorders requires add-on therapies on their prescriptions. So in general, people with CKD are particularly susceptible to polypharmacy due to the comorbidities and also the adverse events that's been following with the disease. And we know that those people not on dialysis actually receive around 6 to 12 different medications per day, which makes adherence a problem. And also this is a pill burden, and this might cause a potential problem of drug and drug interactions and other interactions as well. What we do with the guidelines, we have suggested once we're trying to come up with a suggestion prescription for our patient population, we need to consider our eGFR. And for most of our patients, using the creatinine formulas for eGFR is valid enough. But at some point where we're using the neurotherapeutic or toxic range drugs, we need to have more precise eGFRs than using the cystatin C, and the creatinine C combinations might be indicated. Also, on top of that, we also have to remind ourselves that we have some people with extremes of body weight where we need to consider body surface area rather than the body mass index and the eGFR. And in some unstable conditions where eGFR is not going to work, we have to make a daily adjustments to our prescription so that we don't run into problems. When we promote optimal use of medication in CKD, we also have to take into account that many of our patients are getting advice from non-healthcare providers for using the dietary supplements or over-the-counter medicines or herbal remedies. So we have to know about the medication review at each visit to make sure that we're on the same page with our people with the chronic diseases. But on top of that, some of the patients might develop acute illnesses on top of their chronic conditions, which will require a discontinuation of their drugs, as you were discussing at the previous lectures, actually. So we need to stop at some point. But the critical point to remember is discontinuation might be set up for a point, and there will be a day where we have to restart our patients on their medication so that the progression of the CKD is still under control and we don't lose this benefit of the drugs which we had discontinued and we weren't aware of it. So we need to get into stewardship for our patients. We need to educate our patient population, but also we have to get into contact with other disciplines who are treating our patients, and we must ask our patients to inform their healthcare providers about the state of their chronic kidney disease. But on top of that, we also have to have a collaborative relationship with them and also with the pharmacists, who are also great help in taking care of the prescription in our patient population. For the radio contrast, in this guideline, we just put into the patients into the front, and we said risk and benefits of imaging studies using contrast agents should be determined on an individual basis in the context of their CKD, and using the contrast agent should be dependent on the consensus statements that has been lately published by the radiology guidelines, or the statements actually. And also, patient education and the healthcare provider collaboration is key to promote the drug stewardship among people with CKD. And it's also important to remember that some of our patient population will be at the age of childbearing potential, and we must take into consideration the potential teratogenicity of the drugs that we use, and we need to provide counseling for each of them as well. So in terms of patient education, in making sure that we're prescribing delicately for our patient population, we have to let them know about every effect and the adverse effects of the drugs. And we would like to hear from our patients as soon as possible when an adverse event or an unexpected event occurs, so that we take measures at the right time. And we need to have more availability of the electronic health applications, interactive applications, so that the patients and the healthcare providers are aware of what's going on in terms of the prescriptions. And we should also be controlling what is really prescribed and what is the actual regime the patient is taking the prescriptions as well. And so in terms of disasters or unexpected conditions, having a written information, including a little bit about the eGFR or a lab value which will lead to the eGFR, is critical to maintain the best therapy for our patients as well. But also getting into collaborative relationships with our other disciplines, our healthcare providers. We need to set up some alerts to make sure that the dosing of the drugs that are going to be prescribed to the patient for newer problems should be within the line with the other drugs that we're using. And we need definitely a regular review and evaluation of the medications so that we are not overusing or we're not using less than we should be. Like it was discussed, we need to get to the top of the prescriptions to promote the best available outcomes. So as KDIGO, we recommend a 8-step process of medication review and reconciliation to optimize the CKD management. First is we want to minimize the medication-related problems. So we need to know about the medication list of our patient population, to make a list of the drug interactions, drug disease, drug lab, drug food interactions. And we have to ensure that proper monitoring takes place, like controlling for the potassium. And then we also need to make sure that there is no barrier to the use of the drugs because of availability or because of the lab values or the adherence of the patients. And we need to have an accurate medication list from the patient if they are able to supply. If not, then we need to use the electronic devices as well. And we need to communicate with the other physicians to have a medication agreement and reconciliation, hence because of the other problems that the patients might be running into. And also, we need to evaluate whether all the medications are medically necessary at the point we evaluate the patient. Do they still need these drugs? Do we have to stop? When do we need to restart these drugs? And is there an acute illness that we need to take care of while continuing with our prescriptions? And we need to assess the current therapy, the drug of choice for each indication, and we need to individualize for each patient every time we see it. And also, we need to come up with the right dose, with the right regimen, and taken into consideration not only the eGFR and the stage of the CKD, but also the liver functions or the patient site or the weight. Are they putting on weight or are they losing weight? And then we will have a better management of our prescriptions, and we will be using this medication review and reconciliation to optimize the CKD management in our patients as well. So here I would like to invite all our speakers to our panel, and we would like to hear from you about your questions. Thank you.
Yeah, thank you to all of our speakers for really excellent overviews. And again, nothing replaces reading the guidelines and hearing all the representation in all of its entirety, but I think each of you has synthesized some really key points. We do have time for questions, and just to let people know that Dr. Rossing is going to leave us partway through this panel discussion, and so if there are questions for him, we'll try and get to those earlier than later, but perhaps we'll start with the one that I do have in the chat, which is about protein diet recommendations, Dr. Madero, with respect to their similarity or the sameness in proteinuric and non-proteinuric CKD. And the question as to whether or not, which comes up quite a bit, as to whether or not we have to increase or compensate for protein loss in proteinuric CKD.
Yeah, thank you. I mean, I think that's a very important question. We are not making any distinction between proteinuric and non-proteinuric CKD in terms of protein intake. However, we do say a few things. If the patient is cachectic, has sarcopenia, has protein energy wasting, then those people should not get a protein restriction. The other big exclusion would be kids. So children should not also be on protein restriction because this impairs growth. So, but in terms of changing the protein intake with regards to proteinuria, we are not making any differences on the guideline.
Yeah, and I think that's an important point that is often misunderstood. So thank you for clarifying that. These are combined questions, and maybe I'll ask Dr. Rossing to start first, but people talk about the risks associated with SGLT2 inhibitor use, and I might ask you to put into perspective the difference between relative and absolute risks for the audience, because I think that's a piece that continues to be perhaps misunderstood or overemphasized. So every drug has a risk. There's no question about that. So what are the true absolute versus relative risks of SGLT inhibitor use?
Well, of course, you can evaluate this in different ways, and you can say in many different let's say, strata of kidney function or albuminuria. With higher albuminuria or lower kidney function, your risk for events increases. The relative benefit seems to be the same across almost all levels of kidney function and proteinuria. But that means the absolute benefit is highest in those with the highest absolute risk in the starting point. If we want to put it into different metrics than these 30 to 40% reduction in the primary outcomes in these trials, you could say the numbers needed to treat for 2 to 3 years is in the range of 20 or 30 people. Then you will prevent one of these very clinically important events, meaning that the benefit of these drugs is impressive. If you then want to say what is then the risk, the side effects, ketoacidosis and so on, which has been concerns, particularly in diabetes, although it's a rare event, then numbers of events you can prevent in terms of hospitalization for heart failure, halving of kidney function, or reaching end-stage kidney disease, or having hospitalization for heart failure or mortality from cardiovascular events, then that by far outlines the risk, the small risk in all populations for these potentially adverse events. So yes, there are risks. As you said, no drug comes without a potential risk, but the benefits clearly outweigh the risks. And therefore, it's so important that we implement these treatments. And sorry?
No, go ahead.
No, so I mean that it's really important that we use the agents, and that, as the trials have demonstrated, this is really from a wide range of kidney function, from down to 20 up to normal GFR, if albuminuria is increased, and in those with low kidney function with normal albuminuria, then with diabetes, the cardiovascular outcome trials in combination with heart failure trials and the kidney trials have learned us that that's also a good idea. Whereas if you have CKD in general with normal proteinuria, there's a risk reduction for slow progression or losing kidney function, whereas you could say heart outcomes by themselves were not affected, and that's why the recommendation was less strong for that group of patients. But still, it really is that with just treating 19 people with CKD and proteinuria, you can prevent mortality and kidney failure.
Yeah, and I guess, just to amplify one of the things that you said is that the relative risk of things like DKA in diabetics, or mycotic genital infections, especially in women, in diabetics and non-diabetics, the relative risk relative to control is high, but the absolute numbers in all of the studies was incredibly low. And I think that does get confused in people's minds. And just on another note, again, in the same vein, if you will, there is this notion that urinary tract infections require a cessation of an SGLT2 inhibitor and then a resumption. I think that's really a bit of a myth. And I think we really do need to, and Rümeyza, maybe you can answer this. Like, I think that's no recommendation that a UTI equals cessation of SGLT2, nor is there an association with it. And perhaps that speaks to the medication review and understanding a little bit. Perhaps you can comment on that.
Yeah, thank you. I totally agree with you. There is nothing to recommend cessation of the drug for ITU infections, but we have to remind our people with CKD when we are starting these drugs what is expected of the outcome, and reporting any unexpected experience that they are having, so that we intervene at the beginning before the infection or the symptom gets severe, so that they stop the drug. That's what's happening. And actually, I might be taking your role, but I saw in the quick QA, there was this question about the patients being anxious about add-on therapies. But
right.
As with these guidelines, we are putting our patients in the center. And of course, what is risk and benefit ratio, and what is the adverse event and what we will gain by adding on these drugs. Of course, with the proper indication at the right time for the right patient, we also have to take into the preferences of our patients, but also the availability of the drugs and the local culture and etc. That's also important, because we want, once we start the therapy, we want it to continue unless something unexpected occurs. So that's also critical, and making sure that we give enough information at the beginning probably will be important.
Yeah, and I think also in the guideline, we recommend a medication review, and there are times that you can stop or reduce the dosage of other medicines. And perhaps that's another way to manage the apprehension about adding another drug, that there's a possibility that you could reduce something else. So yeah, thank you very much for that.
Maybe we can just add that all these days, it's more than 90,000 people that were treated in these different trials, and meta-analysis clearly demonstrate the kidney benefit across all subgroups. So that, and again, the risk benefit, as you point out, is clearly in favor of treating. So therefore, it's really important that we apply this.
Yeah, and I think that is one of the really important messages of this guideline in general, and this session in particular, is to really, as a team, to work together to try and make sure that people are on the right medicines and having the right diet and having the right approach and understanding to the totality of their condition. There is a question, I'll direct it to Dr. Madero, in terms of uncontrolled hypertension and chronic kidney disease. And how would one address it? It kind of is combined with, can we prescribe MRAs instead of non-steroidal MRAs for patients with albuminuria? Like, they kind of could go together in some ways.
Well, I mean, I think, thank you for the questions. I'll start with the MRA instead of non-steroidal MRA, and then go on to the hypertension. So, you know, MRAs are indicated if the patient has heart failure with reduced ejection fraction. However, you know, in our in the guideline process, the evidence review team looked at MRAs, specifically spironolactone, for chronic kidney disease progression and outcomes, and there was no data there, right? So non-steroidal MRAs are indicated as of today in diabetic patients, right? And this is something that's important. We do not have any evidence for non-steroidal MRAs in the non-diabetic population. We may in the future, but we don't have it as of today. So to me, you know, going back to the first question, for uncontrolled hypertension, spironolactone could work actually pretty well, right? But then the risk is hyperkalemia. So we need to balance the risks and benefits. And, you know, spironolactone in the setting of chronic kidney disease without heart failure, we would only use it for people that have uncontrolled hypertension. We use calcium channel blockers. If the patient has a history of cardiovascular disease, then a beta blocker, it's a good idea, right? But obviously, this would be on top of optimizing the dose of RAS inhibition. So, you know, it's not uncommon for our CKD patients to have 3 or 4 blood pressure medications in order to be able to control their hypertension. And, you know, up to 90% of the people with later stages of CKD have difficult to control hypertension. So, you know, I think that's an important point.
Yeah, no, thank you for that answer. And I think, yeah, we'd all agree. I think we're waiting for the data for non-steroidals and albuminuria and non-diabetics, but they're not there at the moment. There's many people that believe that the escape hyperaldosteronism that occurs with those of our patients is worth a try at attenuating it, but obviously with safe drugs, and goes back to Rümeyza's point about making sure that we review the medications and have appropriate medicines for everybody. This is for all of the panel, really, is your experience with SGLT2 inhibitors and increases in hemoglobin or erythropoiesis. Who wants? Peter, would you like to start with that?
Yeah, I can start and say we looked into the DAPA CKD trial, and it was actually, we wrote a paper on that and actually suggested that it could be EPO sparing because the effect on hemoglobin on average is quite clear. And in a lot of the SGLT2 inhibitor trials, actually, if you correct for the change in hemoglobin, then that seems to explain a large part of the benefit. Whether that's a causal mechanism or but just an association, we don't know. I like to stress that. But just to say that it's a clear finding that there is an increase in hemoglobin, and it might reduce the need for other ways to treat anemia, at least in some patients, and it seems to be associated with a benefit. It was also speculated that that might be associated with a risk, but so far that has not really been confirmed. So I'll say that there is an effect. It's quite clear and associated or seems to mediate in some way in mediation analysis the benefit.
Yeah, no, thank you for that. I think this is certainly my experience clinically, that there is a rise, and it obviates the need for starting something, including iron therapy. I've been quite impressed with. Magdalena, Rümeyza, have you had the same experiences?
Yeah, I mean, I don't know, there's hemoglobin increases a little bit, at least in our clinical practice, we have seen that. And it's quite nice because, you know, it's very difficult to give IV iron to the chronic kidney disease patients that are not on dialysis. So it's, you know, helpful that way. That's my own experience that are in our own clinic.
I would say the, you know, hemoglobin levels stayed stable. I would say just comment about that.
Yeah. No, and I will just parenthetically say, and nobody is phlebotomizing these people because they're have naturally higher hemoglobins. I saw some interesting data this morning with respect to some of that change is explained by the sodium diuresis and some hematocrit changes without a change in erythropoietin levels per se, but nonetheless, as Peter said, it's a true phenomenon and it is very interesting. Perhaps a last question, which is actually good, is how do you manage water retention in people with CKD not on dialysis? You know, I'm assuming the question is being asked in the context of somebody already being on a diuretic. And maybe, Peter, I know you have to go shortly, but so maybe I'll ask you to take a first stab at this and then I can pass it on to others.
Well, I think first thing is, of course, to use diuretics, as you say, because I think if we look into many of the large outcome trials, there's many people with CKD that are not on diuretics, which is a bit concerning because at least people with diabetes and CKD often need a diuretic to control blood pressure, and therefore I think use of diuretics is important. Then sodium intake it can be relevant, and I think that's at least what we focus on mostly, that is to apply relevant diuretics and to go from thiazides to loop diuretics when kidney function decline, but and then be aware of sodium intake. Then, of course, in very advanced CKD, it may be an issue even with these treatments, but maybe I can defer that to you that are the nephrologist and just being an endocrinologist.
Not just, we're all partners in crime here. Rümeyza or Magdalena, anything to add to that?
I mean, I would just say that we are adding combinations of thiazide diuretics with loop diuretics. And this used to be thought that, you know, thiazide diuretics were not as helpful in later stages of CKD, but now we know that, and there's a couple of trials that have shown that, you know, you do have a decrease in weight, and it could be 2 to 3 kilos. So synergistic effect and blockade of the nephron at different stages, it's helpful. And of course, you know, the SGLT2 inhibitors helps us as well with sodium and volume. And I would just add that, you know, we shouldn't be afraid of the loop diuretic doses, and that it's very important to give them, you know, at least twice a day. I give them 3 times a day because I see a lot of the times, you know, non-nephrologists prescribing very low doses of, you know, furosemide or bumetanide in order to manage volume. And this is not going to happen. You know, you need the tubules to secrete this, right? So we need higher doses, and we shouldn't be afraid. And I ask our patients to maintain their weight keepers. So at least have them bring their weights and their blood pressures to clinics, and that's, you know, a way of guiding them.
You know, really good points. Rümeyza?
Thank you, Dr. Madero. To add on to what you have said, that's why we need to have records of what the patients are taking. They might be under-prescribed because of the non-awareness of the EGFR and the potential mechanism of the drugs in CKD, and also reminding ourselves about the sodium intake is going to be critical. In agriculture, there are other diet materials which might contain more salt than we think. So going through the salt-containing diet is going to be critical as well. That's one of the major steps that we have to consider.
Yeah, and I guess also the same way that people are afraid that the creatinine changes with ACE inhibitors and SGLT2s, there remains a huge nervousness that the diuretic is damaging the kidney. The patients tell me this, the GPs tell me this. So we really need to get rid of that myth as well in terms of this is just unmasking true kidney function in a waterlogged individual, and that you're not hurting anything, and that the water is what's hurting things. So I think that's absolutely true. Yeah, no, I think this has been an excellent discussion. What I'd like to do is actually just try and summarize for everyone where we're at. And so we really tried to emphasize the holistic approach to the management of chronic kidney disease, and that it requires this combination of lifestyle modification, pharmacotherapy, regular risk and benefit assessment along the patient journey over time by the team. That the healthy lifestyle that includes not just exercise, but also this balanced, ideally plant-based diet is really, and cessation of smoking obviously is important for preventing both the onset and the progression. That the way that we use the pharmacotherapy to delay or halt the progression and to manage the comorbidities, yes, it results in polypharmacy, which might be difficult, but perhaps there are drugs that are not helping and not working that one can deprescribe and keep the ones that truly have an evidence base behind them to do that. And we've talked a lot about the different aspects of care. So this multidisciplinary communication, both within the team as well as with other specialists and primary care physicians, is really important to the holistic management, with a very regular review of this multitude of medications, with very much, as Rümeyza said, putting the patient at the center at all times. And so with that, I really want to thank our speakers who were excellent in terms of synthesizing a very large document of knowledge, and also to remind this audience that on April 30th, we'll have a third webinar in this series looking at the application of guidelines through interactive patient cases with Dr. Ahmed, Dr. Schlipak, and a conversation around case studies, which I think will be very helpful in terms of putting things in perspective. So again, a very big thank you to the three of you for your excellent talk, the support of KDIGO and the staff, as well as Science Collected, for this really excellent and professional conversation that we've had. And hopefully all of you have found it very, very helpful. I certainly have. So thank you, everybody, and thanks for your attention. And please do remember to complete your evaluation form so that we know how to do these better and directed towards you. Thank you.